All right, so today to start off this session, well, let me just say that I know it was last minute, but try and register on the website, because that's where I'll have all the resources, and including I'm taping this presentation, so unless otherwise somebody says something else, I have your informed consent for the taping, and I will put that on the website. It will be on YouTube, but on a private channel, so there's privacy. And what else? And also try to introduce yourself on the Google slide, so I could have a more broad idea of who you are, and we'll get to know each other in the next few weeks. So today we're going to talk about clinical research in public health emergency, specifically ethical challenges for the Research Ethics Committee review during COVID-19 pandemic. So let's right. So this slide shows the plan I have for you today. We'll first go over some definitions. We'll just briefly review about previous epidemics, pandemics that have surfaced in the last 50 years. We'll talk about the importance of doing clinical research during these pressing times. And then we'll talk about challenges for research ethics committees, which include this concept of research exceptionalism. In other words, do we do research differently in the times of pandemics? We'll talk about innovative study designs, timely review, performing timely review without undermining substantive protections for research participants. We'll talk about expedited review. We'll talk about whether there should be tolerance for riskier research during pandemic times. We'll talk about challenges for informed consent. We'll say a few words about social media recruitment during the pandemic, and actually social media recruitment has been going on for the last several years, even before the pandemic. And we'll talk about the importance of data and sample sharing during times of pandemic, especially during the times of pandemic. So let me, do you all have a QR code on your smartphone? Could you scan that code? Yes, okay, thumbs up, right. There's many different ways to interact. Okay, so why don't you scan that, or you could connect by going to that website there. So I'm just trying to make this session as interactive as possible. I see 9 people have joined. Okay, and so which is good. I think there's 12 people here. I think I counted myself twice. All right. So the first question is: have you? This is a simple question. Okay. Have you reviewed COVID-19 research in your IRB? Yes, no, and I'm not sure. Okay. All right. So 4, 2. Okay. All right. This is anonymous. All right. 8 people have voted.
There's an error message coming for me. It's not allowing me to submit.
It's not allowing you to submit?
Yes.
Yes, me too.
I also.
Huh.
Should we scan the QR code once more?
Submitted right now.
Cynthia refreshed the page. I refreshed it and now it worked.
Okay. All right. Very good. Thanks, Hamda. All right. So a large proportion has said yes. 78% said yes, and two have said no. Okay. Very good. So actually, there was a meeting that occurred in Egypt in March, and they asked the same question of the audience: have you reviewed COVID research? And that was back in March, and a minority of REC members said yes, but this is October, and obviously there's been a lot more COVID research being done since that time. So IRBs are doing a lot of research. Reviewing COVID research. Investigators are doing a lot of COVID research. All right. So, do you? The next question is: do you think performing research during a pandemic increases the possibility that most participants are vulnerable? I'm not sure. Yes. Okay. Okay. A large proportion. All right. All right. Well, all right. We have mainly yeses and not sure. Nobody says no. All right. Now for a more challenging question. Oh, well, this was again the results of a poll asked of that at that meeting back in March, and most people said yes at that time. So now the question is, what would be the cause of such vulnerability? Why don't you choose what you think is the most relevant? Why, if you think that, doing regular research, people are vulnerable, but why do you think is the major reason for them being mainly more vulnerable? Okay, we have this concept of medical vulnerability, social vulnerability, dependent, institutional. Okay, all right. All right, good. So now all right, economic? No one is choosing economic. Okay, all right, we have to discuss that. I say that only because I think it isn't that I think. A lot of people are more impoverished with job losses and losing healthcare access. I don't know if that's happening in the UAE, but it is widespread. Okay, so social, medical. We'll have I don't want to take up too much time with this. At some point, I like to unpack the term, what is meant by social vulnerability. But medical vulnerability, one concept of medical vulnerability is that patients are desperate for a cure or for a treatment, and hence they would sign up for any research studies, and that is what is meant by medical vulnerability. A prototype of medical vulnerability occurring in normal times occurs with oncology patients who are exhausted all their chemotherapy, and now they're presented with a trial for a new type of chemotherapy or an approved chemotherapy, but for a different indication. And we usually say those patients are desperate to sign up for any trial, and that's what we mean by medical vulnerability. Okay, very good. All right, so some definitions. And by the way, feel free to interrupt me at any time. And I'm not monitoring the chat box, so my trusted IT person, Yogesh. Some people may be wondering, who the heck is Yogesh? Yogesh, raise your hand. Yogesh is my trusted back end. He helps me with these websites. So Yogesh, if you think somebody has asked a pressing question, why didn't you stop me? Okay, very good. So what counts as a global health, or you could unmute yourself and just chime in. I don't mind being interrupted. Okay, so what counts as a global health emergency? Global health emergencies are of concern, global concern of more than one country. They can have many causes, like infectious disease epidemics, like what we're having now and previously Ebola, measles, Zika virus, or SARS. or natural disasters such as earthquakes, tsunamis, floods, or hurricanes, and human-made disasters such as large-scale industrial accidents like what happened, unfortunately, in Beirut, times of conflict, what's happening in Syria and other countries in the Middle East and also throughout the world. Previously, we had the 1918 influenza pandemic. About 500 people became infected, and at least 50 million people died at that time. Then recently, the SARS pandemic in 2003, and then the H1N1 pandemic in 2009, and then we had the Ebola outbreak in West Africa, 2014, 2016, and we'll come back to the Ebola conflict because some interesting controversies occurred with doing clinical research at that time that has relevance for what's happening in our situation. I forgot to ask. I thought I had a question. I thought I had a question on the website, but why didn't you actually, let's try a different way to respond. Why don't you, in the chat box, let me ask you, what do you find to be most challenging in reviewing protocols, in reviewing COVID protocols? What do you find to be most challenging in the last few months? Why don't you just write that in the chat box? Okay, large clinical trials have required time to review and lack of previous safety data. Okay, we'll talk about that. No previous references or evidence due to the novel nature of the virus. Okay, a lot of uncertainty. Off-label use of treatments. Yes, there's been a lot of that. I'd like to unpack why that is challenging. The use of off-label treatments, standardization of protocol. Okay, why don't we get a few more? Stringent timeline. Okay, great, good. Yes, time. We'll talk about that. All right, this is a good time. So we have time pressures, off-label use of treatments. We'll talk about that, and a lot of uncertainty with the nature of the virus. Ethical part. Yeah, but which ethical issues are troubling you? And large safety trials, lack of safety data. Okay, yeah, lack of safety data. We'll talk about that in terms of tolerance of risk. Okay, very good. I'm glad I'm going to address these issues. Okay, vaccine trials. Right. Okay, good. I'm glad you said that because that will be the on the agenda for next week. The vaccine trials. Okay, very good. All right, so lessons learned from the previous epidemic. So what kind of research is needed during global health emergencies? Well, we need to improve understanding of the concerns of people affected by the emergency. Improve understanding of the concerns of people. So good. Social behavioral research, make diagnosis quicker. So testing, develop new vaccines and treatments for diseases that cannot currently be treated or where treatment options can be significantly improved. That's for sure. Adapt existing ways of caring for people so that the services provided are appropriate and sensitive to their needs and provide health services in very challenging situations. Okay, so global health emergencies are challenging environments in which to conduct research. They involve disruption of people's lives and great health needs and other urgent needs, not only medical needs, but social economic needs. They are likely to be accompanied by time pressure to act that may be in tension with standard research timelines. Some of you have already mentioned that. There's anxiety and distress on the part of participants, researchers, and the wider community where the research is taking place. Other challenges for researchers include rapid turnover of workers active in the emergency, the inherent dangers of the emergency setting, the tension between doing research and the immediate emergency response, especially in the face of great need. So actually, a lot of researchers are needing to take care of the patients, and they don't have time to be able to do the research. But there is a lot of research going on nonetheless. So now we need to do the research during these trying times because there are risks of providing inadequate, ineffective, and even harmful care if we don't research these treatments. Someone mentioned about using off-label of drugs. We'll get back to that in a few moments. So actually, if you check clinicaltrials.gov, it just seems like everybody is just picking any off-label drug that has some anti-immune effect and using it in patients. They use it in research as well, but sometimes you wonder what's the rationale of using some of these off-label drugs. So the research provides much needed evidence for clinical management and public health decisions in an infectious disease epidemic. For many emerging infectious diseases, effective diagnostic medications and vaccines are simply not available, and we need to do good research. And where these medical countermeasures are available, the evidence for their use is quite frankly, limited. So the types of research investigating the virus itself, animal environmental research on the origin of the virus, epidemiologic studies, and there are a lot of epidemiologic studies. I've reviewed the research that you have reviewed, and I see that you have reviewed a lot of epidemiologic studies, a lot of retrospective studies as well, clinical characterization and management of the infection, prevention and control, including healthcare workers' protection, also including the stresses on the healthcare workers, therapeutic research and development, vaccines, and social sciences in the outbreak response. So a lot of research, but time is of the essence. The point at which an epidemic occurs is the only time to gather the data. We can't wait until the epidemic is over, and we have to generate new knowledge regarding disease characterization, prevention, and treatment. Experience from previous epidemics highlights how time and the research response has been delayed previously, and there's a narrow window of opportunity for enrolling patients during the peak epidemic waves is missed. Actually, when is the best time to test a vaccine? The best time to test a vaccine is when there's a lot of infectious cases. Think about that. We'll talk about that next week. But if the pandemic is well controlled, you don't want to go to that place to test your vaccine. You want to go to a place where the disease is rampant. Again, we'll talk more about that next week. The window for learning in pandemics is often short, and there's a need to balance. However, there's a need to balance scientific rigor against speed. Seems inevitable. Now, let me ask you a question. Should one relax the requirements of rigorous research in order to speed up research? Time is of the essence. Should one relax the requirements of rigorous research? Okay, one person starts out, and I sense that's an emphatic no. Okay, all right. All right, so remember, this is anonymous. That's why I don't do it on the chat box. Should one relax the requirements? Personally, I would have voted not sure. It seems like the socially accepted answer is no. Of course, it all depends on what we mean by which requirements of rigorous research. And we'll talk about that. But as well, someone mentioned before, reviewing research without previous adequate safety data done in animals, right? So is this a time in which do we need to, it all depends on how much uncertainty are we willing to accept during these times of pandemic in order to move forward faster with finding a treatment, because as you can see, thousands of people are dying every day throughout the world. So should we relax the requirements? And so that's an important question for research ethics committees when you review research. What's your tolerance for accepting research that's less rigorous? And let me say now, there is research. There might be, let me just say now, there might be research in which one could relax the requirements. However, there's a blurred line. We'll talk more about that. Okay, good. Thank you for your thoughts. Okay, to be effective, research must be fast, flexible, and integrated with the frontline response. In order to enroll enough patients to get an answer quickly, there is a need for multi-site, multi-country research, and that's been done with the WHO, with the Solidarity trial, and in the UK and Europe with the Recovery trial. So there's a need for multi-country research to enroll participants faster. And however, we have to navigate the requirements of multiple regional and national administrative and regulatory systems. And this slide shows all the different factors that affects research that we have to we have to not consider, but we have to consider not only the ethical aspects, but also regulatory, administrative, economic, research funding costs money, logistic, societal concerns, and political concerns as well. Don't get me started with the political concerns that's happening, what could I say, in my country. But I just want to say I voted last week, okay? But I'll stop there with the political issues. Okay, so now, let me ask you, what kind of ethical issues, if some of you already mentioned a few, but what kind of ethical issues become more pronounced during the pandemic? This is something that you write down. Okay, vulnerability of participants. Okay, this is probably just a summary of a lot of things we already said. Balance of benefit and harm, vulnerability, control groups. Okay, very good, very good. Justice, good. We have to unpack that term as well. And let me just say that there's a lot of issues about equity. And other thoughts? Safety, okay. All right. Have one more. Okay, informed consent. Very good. I was waiting for that. All right. So let's bias. Somebody wants to say more about the bias in regards to research design or bias in selection of participants? Maybe we could unpack that later. Transparency. Okay, good. All right, very good. So what kind of ethical issues? Appropriate study design that's sensitive to the difficult context in which research is taking place. Performing flexible review. I like better to use the term flexible review as opposed to fast review. Fast review sometimes gives the notion that maybe you're cutting corners. Enhance. All right. I want you to know I finally found out the reason for the echo. Okay. I see a few people smiling. See, I like that. I'm sorry, I apologize. I had my speaker on. I thought it was off. Anyway, back to the presentation. Enhanced risk to research due to uncertainty of the effect of drugs. Someone has mentioned that already. Achieving meaningful consent processes to ensure people's interests are respected. Also, equity issues. Someone mentioned justice. Emergencies disproportionately affect people in low-income settings, those who are already marginalized or deprived. Issues about community engagement. Essentially, are we hearing the voices of the community? Are we able to still engage communities when we design research, which involves questions of power and influence? Great effect when we collaborate with investigators in other countries. Is there fairness in these collaborations between the researchers and research institutions in different countries? And what about data and biological samples? Are there fair collaborations when we share data? We need to share the data and biological samples in order to achieve faster answers to pressing problems. Now, this slide is a little busy, and I put this in, so I'll post these slides in the on the website. But the values, we have to look at fairness, equal. Right, yeah. So we have to equal respect for individuals, communities, our research design, sensitive to the local values. We'll talk more about that, about what happened in the Ebola epidemic. Do we ensure that participants are treated safely during these trials with so much uncertainty? Is there fairness when we do the research? Do we distribute the benefit and burdens of the research equitably between the different populations? Do we make sure that the processes of research are transparent? And then we have help reduce suffering, considering whose needs are being met by the research, who has defined these needs, who decides what research should be done, and are these the most important research studies that are being done? So getting back to the issues. Now, there are three issues to consider, barriers that could delay research, and one regards problems with the regulatory environment, doing research in collaborations, and then we'll spend some time on the innovative research designs. And those are several important barriers to doing research during these times. So we have to have enabling regulatory policy and social political environment. Clinical research operates in a wider policy, regulatory, social, political context. Key features of that context can operate as a barrier or an enabler, and then processes and mechanisms for rapid response are needed. So we have to have, not only do research ethics committee are under time pressures, but there are regulatory on time pressures as well. For example, I don't know what's happening in the UAE, but in the US, there has been a lot of pressures on the FDA to fast forward the review process and also issue emergency use directives for medications. And I'm sure you might be following the issues about approving a vaccine sooner rather than later. And then there's issues about partnerships and collaborations, which require strong interdisciplinary and cross-border collaboration. However, there could be multiple challenges to building equitable, fair, and mutually supported partnership. Let me skip that. So now, getting back to the issue of research design. Okay, so let me ask you this question. Now, we all know about the randomized controlled trial design. That's supposedly the gold standard. So the question is, when current standard of care is ineffective, someone mentioned previously the use of off-label drugs. Okay. Now, interesting, with off-label drugs, we have the safety profile. Now, for sure, we don't know the safety profile of testing a off-label drug in a new disease that could bring up other safety issues. But when the current standard of care is ineffective, is it ethical to randomize patients to stand to a standard of care control group when testing an already approved drug, approved for another indication? So let me ask you, when current standard of care is ineffective, and it has been ineffective for this pandemic, is it ethical to do randomized controlled trials? Randomized patient to a standard of care control group. Is that where we relax the requirements of rigorous research? Okay. All right, so 6 people have voted. Let's get some more votes. When standard of care is ineffective, is it ethical to randomize patients to the standard of care? Is that the time? Is that an area? So 50% says no. A third says yes. One person said not sure. Okay, but only 6 people voted. Come on, let's get some more votes. It's okay to put down not sure. There, I put down a not sure option so that everyone could vote. No more takers? Okay. All right. I won't press the issue. So during the times of Ebola in 2014, there was a lot of concern about trying to randomize patients to a placebo group at that time. The thought was that the mortality of the Ebola was as high as 70% in some communities because of the lack of effective treatment. And so when conventional care means a high probability of death, is it ethical to randomize patients to the placebo group? And the assumption was that interventions in the early stages of development was more like that. The assumption was that off-label drug might be more efficacious than the placebo group, and hence there was a thought that we had a lack of equipoise. That people thought that an approved drug, an off-label drug, was probably more likely to be efficacious than the high probability of death, and hence there was some guidance saying that it was unethical to have a placebo group. Also, the other thought was that a lot of communities had a lot of mistrust of the research enterprise, especially when they saw that expatriates were getting drugs not in the context of a clinical trial, and they were saying, why do we have to enter a clinical trial in order to get these drugs? However, the counter argument is that, well, 90% of so-called novel interventions fail to prove to be effective for any indication. And there's the issue of equipoise. Equipoise is when you have genuine uncertainty in the community as to whether which group is going to be more favorable, the experimental drug or the standard of care group. However, we can't confuse the notion of individual equity versus community. Equipoise. So community equipoise is when a significant minority of clinicians are uncertain as to which group is going to be more favorable. And for sure, there might be a lot of individual equipoise, but individual equipoise should not be the more favorable voice in what study design to choose. And in fact, they started a few studies with the Ebola without a control group, and that had a lot of pushback. And the thought is that there is equipoise during the times of pandemic, and that's one of the times in which you should not relax the rigor of research, because it's hard to interpret non-randomized control trials. And essentially, the concern with the communities is that you have to communicate reliable information to communities and gain their trust. And you have to gain their trust in the beginning of a pandemic and be transparent with the communities as you try to enroll participants. So Now, having said that, there still is the concern about randomizing patients to a placebo group in a 1-to-1 ratio. So there is this concept of an adaptive clinical trial design. So the question is there a way to minimize the number of participants to a placebo group? And essentially, one type of adaptive design is to test multiple drugs at the same time against a placebo group. So an adaptive design is a design for clinical trials that allows for prospectively designed changes. So as you go through the clinical trial, you're getting information about one of the various groups, and you could modify your clinical trial as you get this information instead of waiting until the end. So this is a schematic of such a type of clinical trial where we have several different groups, and you want to add convalescent plasma in the adaptive or factorial design, and so everybody gets convalescent plasma, and in one group you have standard of care, but all the other groups you're testing other drugs, and so this slide shows 5 different groups. So at least in four of these groups, they're getting something. And even in this group, getting convalescent plasma plus the standard of care, they're getting something. And so the thought is that you're minimizing the number of participants who is receiving standard of care. And this is the recovery trial of the, I believe it's the WHO who was doing, no, it was the UK who was doing that trial. So this is an example of one type of adaptive design. And now, having said that, that was the WHO solidarity trial is an example of the use of an adaptive design. It was done in, Yogesh is telling me to check my messages. So, okay. All right, good. All right, let me go back to the presentation. Okay. So the WHO solidarity trial was testing 4 different types of drug combinations, and then we have the a European trial that was also testing multiple drugs that you see on this slide. And then another European trial. Again, the greatest strength of a non-adoptive trial or a regular REC does not allow opportunities for modification during the trial. Again, during the trial, you're doing more interim analysis, you're getting more data, and you may drop a treatment group. And you may add another treatment group. Now, having said that, here is a headline that I obtained from yesterday's newspaper in the Wall Street Journal. I get a lot of my medical information from the Wall Street Journal. I don't have any stocks. But anyway, so the reason for this headline, study adds to the remdesivir debate. So essentially, the WHO, who is doing an adaptive design, showed that remdesivir had no effect on clinical outcomes. And the controversy is that, again, what do we believe? The results of an adaptive design or an RCT. Now, several months ago, the NIH did a randomized controlled trial of remdesivir, and they showed that patients taking the remdesivir recovered faster, 10 days versus 15 days. I'm not sure how important that is. Now, there was some effect on mortality, but it was not statistically significant. However, the WH study, the adaptive design, okay, showed it had no effect. So here we have, and some people are concerned that, well, do we trust the results from an adaptive design? So let me ask this group: have you? I think you might have reviewed the Solidarity trial, a trial adaptive design. I'm not sure. I'm trying to remember, but I'm not sure if this is one of the issues that are being problematic for you. That's one of the challenges for RECs, is trying to review studies with these novel designs. Now there are other types of, without belaboring the point, there are other types of novel designs. There's called cluster trials, where you do studies in villages or communities. And the issue is with informed consent, you actually, in some cluster trials, you don't have the opportunity to get informed consent. And then we have the adaptive trials as well. So let me, you all have that sheet of paper that I sent you with the list of clinicaltrials.gov, right? Okay, let me, let's do a breakout room for just about 5 minutes. You have that sheet, okay? And these are clinical trials that I got from clinicaltrials.gov. I just gave you the bare minimum of information. I gave you the title of the trial, the study design, the number of planned enrolled participants, and the outcome variable, okay? I want you I won't hold it to you, but I want you to discuss in the group which of those trials you would consider approving, okay? So let me, okay. I'm opening up, and I'll let you know when to come back. Okay, you're gonna see a message that says join. That's it. Join your breakout room. What aspects of these studies were most problematic?
This is Dima, if I may share our thoughts.
Okay.
For the first couple of studies, for the first one, we thought that using a strong drug like sirolimus, while the outcome was just looking at signs, made it a little bit hazy. So, and also the second one, we thought that this is quite a large number of patients required to look at post-COVID fibrosis, and whether you could obtain such sample size, and then you're going to treat them with steroids and look at their imaging. So these were the first two that came out.
Oh, okay. All right, good. So you're using, I mean, steroids is not a, a benign drug. And somebody mentioned before in the chat box about previous data. What is the thought behind I mean, we sometimes use steroids in pulmonary fibrosis. Uh, but okay, all right, good thoughts. Um, other thoughts as you look through
Yeah,
these?
I would take the licorice trial out as well,
Which one?
because the complementary intervention trial, that
Okay.
the gum and the licorice, because it just looks at the seroconversion from positive to negative, while it doesn't look at any clinical parameters or even biochemical parameters.
Okay, right. And also what kind of study design is it?
Non-RCT.
Right, okay, good. All right. And what about this? What about this study here?
I'll take this out because as we said in the group, that this has no description of its endpoints at all. What are the endpoints that will be monitored?
Yeah, I couldn't find the endpoints, which is rare. So I wasn't trying to hide it. All right, good. What about this study here?
This study, if you talk about now, I would not take it because we have anticoagulation is a standard therapy right now.
Okay, all right.
I'm also wary of composite outcomes. It's sort of
okay, good.
It's looking for any beneficial any beneficial effect.
Right. Okay.
Yeah, that's true. Yeah.
Yes.
Okay. And then this. What about this last study?
Also, I won't take it because we have many large studies which have proven already that steroids are beneficial. The recovery trials and many other trials that have used as well methylprednisolone or hydrocortisone.
Right. Yes. Now, even if we didn't have those studies, would you approve this study?
Also, the endpoints are weak, very weak endpoints.
Right. Okay.
And it is retrospective.
Right. Yes. Right. Okay. All right. So I didn't make up these clinical trials. Okay. I got them off the website, clinicaltrials.gov, and all these studies were approved. And the point I'm trying to make is there's issues about study design, the non-RCT retrospective, and if it is an RCT, what the heck is this about? When 15 patients? Are you serious? And then we have 50 patients, 70 patients. Now, somebody mentioned if this was a phase 2 study, then you usually have 50 to 100 patients. And maybe I should have added whether this was these studies were phase 1, 2, or phase 2 or 3. But a lot of these studies, even for a phase 2 study, is a small sample size. And a lot of you appropriately had concerns with the inadequacy of the surrogate endpoints. And that's a concern. I remember I used to do, I'm a critical care physician, pulmonologist, and I used to be involved in clinical research in the ICU, and we always thought that a good surrogate endpoint would be the inspired oxygen concentration and the arterial oxygen concentration ratio. We thought that would be a surrogate endpoint, and it has been shown that people could improve their oxygenation, and when you do a trial looking at mortality, it had no effect. So even when you think the surrogate endpoint is a good endpoint, it winds up not being a surrogate endpoint. And that's the problem with why you do a phase 2 trial, and you can't, what am I trying to say? Usually a phase 2 trial is not designed to look at mortality. It's not powered to look at mortality with a small sample size. So you use a surrogate endpoint, the surrogate endpoint looks good, and then you do the phase 3 trial and you get no effect. So that's a concern with a lot of these clinical trials that are being approved. So let me go back to my presentation. In this article here, Against Pandemic Research Exceptionalism, and what is meant by that? Well, do you allow for what I call less rigorous study research procedures when you're pressed for time, and a concern is that a lot of studies are using small sample size, unvalidated surrogate endpoints, and lack of randomization. And so, on one hand, I think there is time to use an adaptive design. Even that is controversial because you want to minimize the number of patients enrolled to the placebo group, but this is not the time to start using small sample size, unvalidated surrogate endpoint, and lack of randomization. So there may be some time for what I would like to call some wiggle room in clinical design, but this is not the point where you would want to make an exception to the study design. Okay. All right. And there's this article that I put on the website, The Carnage of Substandard Research During the COVID-19 Pandemic. This was published just a few weeks ago, and I invite you to look at the article. And I think you all know about how several articles already back in May and June were retracted from JAMA and the New England Journal of Medicine. So what does that tell you about the review process itself? So let me move along. So the WHO cautions against inappropriate clinical trial. Small, observational, non-randomized study will not give us the answer we need, says the WHO Director General. Okay, using untested drugs without the right evidence could raise false hopes and even do more harm than good and cause a shortage of essential drugs that are needed to treat other diseases. There was a time a few months ago where everybody was rushing out to get these anti-malarial drugs or these immunomodulators, and people with rheumatoid arthritis couldn't get their drugs because and who is stockpiling these drugs? It was physicians writing out prescriptions to themselves, and so they could stockpile the drugs. And so there's a lot of concern with doing these practices. Okay, so getting back to the challenges to the REC, this is the next broad topic I want to address. There's a concern about the capacity of research ethics committee to respond in emergency, where novel research designs are presented for approval in an emergency. This creates additional challenges for the RECs. These designs may not be covered by existing guidance nor familiar to a lot of people on RECs. And then there's this concept of expedited review, and we'll go over that in just a few moments. And then now there was a study, a qualitative research study done with RECs, and the RECs identified that the value of timeliness, responsiveness, and rigorousness as key elements of review, even at times of epidemics that we have to pay close attention to. So let me ask a simple question. Does your REC do expedited review?
Yes.
Okay. All right, good. So, well, I'll take it as 100%. Now, having said that, there's expedited review, and then there's expedited review. So, what do I mean by that? A common aspect or concept of expedited review is something called proportionate review, where you reserve for the most intense scrutiny and correspondingly more protection for the most ethically challenging research or research that's riskier, and you spend more time on that. But having said that, so for minimal risk studies, I'm sure you have your own list of categories of research that you would do expedited review. But in times of pandemics, I want you to tell me, have you changed? Have you changed your strategies to conduct more timely reviews? Because I think I was told that now you meet every week. I saw the list of studies that you do, and it's quite impressive. So I'm sure you had to change your process for doing reviews. So how do you do more timely reviews? Okay, weekly meetings, meet more often. Okay. Other than meeting more often and having subcommittee meetings. Okay, all right. So you have a subcommittee, a small group who are able to meet more frequently. Okay. Any other strategies? Okay, more admin work done outside the meeting. Okay. Right, spend less time reviewing low-risk studies. Outsourcing expertise. Send study in advance to the expert in the field. Okay. All right. All right. These are wonderful ideas that you have incorporated in order to meet the demands between meetings, reviews, through emails. Okay. All right. Very good. And okay, these are good ideas. So essentially, here's a list to address timeliness. Most of you have mentioned these ideas. Okay. Convene ad hoc meetings, subcommittees, conduct reviews by teleconference or over email, waive deadlines for protocol submission, right? I mean, sometimes when I submit to the IRB, I get the notice this protocol will be reviewed at the next meeting, like in 3 weeks, I said 3 weeks, okay? Rank protocols by urgency, have advisors pre-review the protocols, okay? Willingness to discuss protocols with researchers at the development stage and provide informal feedback. So by the time it gets to your committee or your subcommittee, all the issues have, all the controversial issues have already been discussed. Excessive initiation of research can be delayed and still achieve the study objectives, and ability to respond quickly to protocol modifications. So this whole list constitute successful strategies in order to enhance timeliness of protocol review. So you are employing all these strategies. Then also responsiveness to offer training for REC members regarding review of disaster research protocols. I mean, you know what type of research is coming down the line. You already looked at, you know, inadequate surrogate markers, sample size, establish policies and procedures, change your SOPs. You mentioned use of knowledgeable advisors, develop partnerships between RECs. What about this concept of central review? If in order to increase the sample size, we're talking about not only multi-country, but have you reviewed protocols that involves different emirates in your country? And would you allow, I mean, is there, I mean, there is this concept of central review, but is that something that to consider? Is that something that's being done? Do two IRBs have to, I mean, trust me, there's a lot of issues to be worked out with central review between different IRBs, but I'm just thinking, you know, unfortunately, this pandemic is going to be with us for a while. So I'm just wondering if that's something to consider within your country. In order to enhance the sample size, should there be cooperation between the different emirates and increase the sample size? Should something to think about. Rigorous, resist the pressure of urgency, provide careful scrutiny of all protocols, especially the high-risk one, and resist external pressures and maintain the independence of REC review. So the issue is you want to do these reviews quickly, but not at the disadvantage of careful scrutiny of all protocols. And there is the concept of proportionate review. If the protocol is low risk, and also if the proposal is going to give meaningful results, then you don't have to spend that much time on those protocols. And you may want to enlarge the category of protocols that you do expedite review. Okay. All right. So another question, which of the below represent major challenges to informed consent? We're going to switch gears. We've talked about study design. We're going to say a few words about informed consent. So which one present even more challenges to informed consent than usual? Disruption in life, family separation. So, we're talking about patients discussing the protocol with their family. I don't know how well you could discuss the informed consent over Zoom. Complexity of the information. some people have a hard time understanding adaptive design, what about our patients? Lack of access to basic resources, we discussed medical vulnerability, therapeutic misconception. I want to be enrolled in the trial, and I want to get the drug, all of the above. Yes, I would say all of the above. All these are more profound challenges to obtaining informed consent for research, and hence I would say all of the above. So, and this slide just summarizes the options in the previous slide. Again, with the concept of medical vulnerability, potential participants may think that this is their only option for treatment. Okay, difficulties of explaining complex study design, and then a theoretical question: is informed consent even possible, given how little we know about COVID-19? And how do we explain the risks? We just have to say that, right, there may be unknown risks that we don't even know about. And that makes it even more complex to get informed consent. So I'm not sure, may be interesting to see, actually that would be a good study to do, to look at the informed consent forms that you guys are reviewing. And seeing whether these consent forms are successfully conveying the complexity, the uncertainty, and whether we need to. I don't know what kind of changes are needed in the informed consent. So it may be a good study to do, to look at the informed consent form and see what kind of changes we should be suggesting. Now, another subject that I brought up previously, should there be a tolerance for riskier research? And I take this notion from this article, Pandemic Ethics, the case for risky research. But before we go into that article, is it ethical to allow riskier research during a pandemic? Oh, I tell you what, instead of voting, give me a thumbs up. Well, we do what I call a body poll, okay? All right? Yeah, just for a change of pace. How many people say it is ethical to allow riskier research during a pandemic? Do I have any thumbs up? Okay, we have a few thumbs up, a few. Oh, okay, people still want to vote. Okay, that's fine. Okay, all right. And, but I forgot the,
I think someone's made the comment, and I agree, sort of define the term risk. What do we mean by riskier? It's sort of a balance between benefits and harms.
Okay, all right, good. So there's risk, and then there's risk, okay? And so I think, I forgot to write down the option, what one represents. One represent yes, so I saw a lot of thumbs up. So the issue is that article talks about this concept of risk parity. We're asking our healthcare workers to take on more risk during this time. So is it only fair to also make an allowance for participants to take on more risk when they go into research. And you ask an excellent question. What do we mean by more risk? So, as someone mentioned before about lack of safety data when you review trials. So, what about skipping animal trials? Getting safety data from animal studies for promising treatments. Do we not demand robust safety data in order to speed up studies? That's one way to think of the notion of something that's riskier, lack of safety data. Is it, now, I asked the question in the beginning of this presentation, is it ethical to allow changes in rigorous research in order to speed up studies? And this may be one way to do research faster. That's a little riskier. And in normal times, the answer would be no. But this concept of risk parity, we are, healthcare workers are taking on more risk. So should that occur in the research setting as well? Now, having said that, an important value associated with this is transparency. We cannot lose trust in the research endeavor. And so we have to be transparent when we do this. And next week, we'll talk about human challenge trials, okay? And what I mean by that is that human challenge trials is when you take healthy volunteers and you deliberately infect them with a weakened coronavirus in order to assess vaccines. And the concept is that that you could come up with a vaccine much quicker. We'll see. We have all these vaccines being tested in the regular field trials. And some people will say, well, we're going to get an answer, okay? However, I don't want to be cynical here, but the concern is that a lot of those vaccines are not going to be as effective as we want them to be. And human challenge studies, I'll just say a little bit about them now, is that human challenge studies, by having a human challenge studies, you'll know which vaccine will be possibly more effective before you test them in field trials. So there is this concept about should we relax our guidelines or our tolerance for risk? Okay, just something to think about as you review your studies. Let me just say, let me wrap up, and let me just say a few words about using social media as a research recruitment tool. Let me give you a personal experience. I've been doing a lot of survey studies regarding biobank research, which we'll discuss in a few weeks. And we were doing surveys. We wanted to do a survey of the lay public, investigators, and members of RECs. And we put on hold our survey study for the lay public, and because we were concerned about we wanted to do surveys with the lay public with data collectors as opposed to just sending them a link. to go to and fill out the survey. But, and we wanted data collectors to go into hospitals and recruit patients and people in the waiting room. And then COVID came along and we put that on hold. But then recently we started putting out Facebook ads as a recruitment tool. And let me just, I don't have time to go into all the major issues, but the major issues would be the ethical issues with recruitment, would be privacy and transparency. Privacy regarding the data. Now, let me just say that some people say, well, there's public and private data. If people use social media, that's public data. However, it's blurred. We say public data is, could be used for research purposes and probably without informed consent. However, there's public data and then there's public data, and we still have to respect privacy because a lot of people go on social media. They don't expect their data to be used for research. And then there has to be transparency in terms of do we get research data as we work on these platforms and put on a cover as a participant as we join these chat rooms. So there's a lot of data, a lot of issues with not only using social media as a recruitment tool, but also using social media as a research study. And we don't have time to go into these cases, but an REC checklist for reviewing the issues of social media as a recruitment tool. We want to, whoops. What happened here? Get back. Oh, what happened to my? That's the wrong presentation. Bear with me. Oh, okay. Sorry. You want to make sure that a proposed recruitment does not involve deception or fabrication of online identities. We want to make sure the trials are accurately represented in recruitment processes. We want to make sure that the proposed recruitment does not involve members of the research team working on social media. It's almost like the distinction between recruitment via an email and a phone call. Recruitment by a phone call is not considered good practice. That's invasion of your privacy. And an email is better than a phone call. The problem is, where does recruitment on social media platform occurs between email and phone call? And are we invading privacy when we try to recruit on social media? And then the last thing I just want to gloss over, because time is tight, data and samples. And it's the whole issue about data sharing. So let me just ask you, data sharing are urgently needed to reduce the duplication of work and provide a clearer picture of epidemiology and pathology. and there are principles for data sharing. And I'll just do a body poll here. Have you been needing to review the clinical studies you review? Do they incorporate data sharing? And if so, does your IRB review material and data transfer agreements? Is that something that you do, you're familiar with, or haven't had? Okay, all right. Yeah, so that's, I know, what could I say? Some countries do not allow data sharing or do not allow transfer of biological samples. Of course, there are boundaries. And, you know, in this pandemic world that we live in, we have to collaborate and get more data much quicker. So, and then let me just mention about community engagement. Some studies would require the input of the communities in the design and performance of research, and I'm looking at the studies that you have reviewed. I think a lot of your studies are not requiring community input unless you need it for, you know, to help out with the informed consent process. So let me just let me ask you one last question. Okay, would you agree to be a research participant in a COVID clinical trial? Yes, no, not sure. Depends on the drug. I'm assessing your value of solidarity.
Sure, not sure.
Yes, no, not sure. Depends on the drug. Okay. All right. Okay. All right. Something to. I always find the hardest individuals to recruit for a research study are doctors, or investigators. Okay. And I don't know why, but maybe they know something that we all know about. So let me just say, this was asked at that previous meeting, and less than 50% said yes. About 25% said no. Oh, wait a second. I'm not sharing this. Well, yeah, I'm just realizing that for some reason I'm not able to share that. But anyway, you're not alone. And so if you think you have issues about sharing the there we go. So, oh no, but I don't know if you're, oh, there we go. Right, okay, you got it now. So, less than 50% said yes. So think about that. If we're hesitant about participating in a trial, think about the people we asked. And, I don't know if more people are saying yes or no. If we think they're more vulnerable, especially with medical vulnerability, they may, I don't know if recruitment efforts have been easier or more difficult during the times of COVID. I don't know if that's been studied, so not sure. So I hope that I've addressed a lot of the issues that you guys have been going through. Hopefully, I brought up some issues that we need some more time to reflect on as we go through this difficult times, and especially with reviewing research. And let me just say, my hat is off to you because you guys have to do a tough job. So let me just say that any remaining thoughts that you may want to address now, or or we could save it on the website. There's a discussion forum. I could have a discussion forum if you want to continue discussing some of these issues that were brought up. Issues about relaxing the standards of reviewing research, the standards of performing research, allowing more riskier research, and our tolerance also for uncertainty, and approving these drugs. We'll see what happens when these vaccines starts to roll out. We'll see. Okay. Any remaining thoughts? Don't
Thank
forget to
thank
go
you very
to
much.
the website and introduce yourself. In a small, what was the question? In a small region like is it ethical to approve multiple vaccine trials? Tell me more about that background behind that question. What do you mean? Are you going to get good results? Is that? What's the issue behind that question?
Medha, maybe you can explain it verbally.
Yes, do it verbally.
Yes, Professor. This is Medha, and this was a question by me. Hello.
Oh, okay. Explain yourself.
Yeah, sure. So my question would be, here we talked about the vulnerability and the participant being compromised when it comes to the pandemic. So as an ethics committee, how ethical it is we approve multiple vaccine trials? Is it because of the competitiveness? Is it ethical to approve multiple trials in a small region considering the sample size?
Oh, you're talking about the sample size, but isn't this part of a larger trial? Aren't these vaccine studies multi-country?
Yes, usually, yes.
Yes,
true.
Yes, multi-center, yes.
Right.
They are multi-center. Yeah.
Right.
Multi-center.
Yeah. So, so I'm just thinking, unless you're, you want to, vaccine studies need to be representative of the general population. Is there a concern that a vaccine may be approved that may not be effective in the UAE population? Is that the concern?
Yes, just being part of the multi-center trials, just to serve a sample size, is it appropriate?
Well, it's I mean, in order to do, well, this is where it comes to the question of having the different Emirates in the UAE get together and decide to just be part of one trial rather than all these multiple trials. Are you actually doing, I know you're doing that Chinese vaccine, right? Are you doing other types of vaccine studies?
The Russian one is going
Russian
on.
one.
Oh, the Russian one as well.
Sputnik.
I say Sputnik.
But it's a small sample for the Russian. In fact, the Chinese vaccine is the one having a big sample. But the Chinese vaccine itself is in fact two vaccines and a placebo. So it's a 3 arms trial.
Oh, two different vaccines.
2 different vaccines. One is from Wuhan and the other one is from another city. I cannot remember the name.
Beijing.
Beijing. Yeah.
I see. Oh, they're doing it within the same study.
No, it is one study, but it is testing 2 vaccines from China versus a placebo arm.
Right. Yeah. No. Yeah. Right. I'm saying two vaccines in the same study. And well, it's going to be difficult for the UAE itself to test your own vaccine because you'll never have enough samples.
No, but they have extended the study already to the many countries in the Gulf and Middle East. So
yes,
it's not only UAE.
You have to in order to get the sample size.
Yeah.
Also, as I'll explain next week, you have to do it in a region where the pandemic is raging.
Yes, that's true.
Right?
Yeah, they are doing it in cities in which there is high infectivity rate.
Right. Yes. And so, time is of the essence, and you need to do these studies in multiple countries. But you ask an interesting question about multiple vaccine studies within a small area, and I'm gonna let me think more about that. Whether initially my feeling is all right, you're contributing to a larger trial, so they'll get their sample size. But I'm just wondering, is there any disadvantage to the UAE population?
Well, right? I don't think so.
Yeah, no, I don't.
I don't think so. I think it's okay.
Yeah, right. Well, first impressions sometimes works,
it's a pandemic, and you don't know which vaccine is going to be successful. And if you participate in many vaccines, at least you ensure a supply of vaccine from somewhere at the end for your people.
Oh, I see. You're distributing your chances of
getting a vaccine.
What assurances do you have that the vaccine will be available to you guys?
Nothing, but we have we have no insurance of being able to produce a vaccine ourselves. And even some of the countries that have produced a vaccine, their vaccine have been bought already by another country.
That's right.
It's a political issue rather than ethical issue.
That's right. A lot of countries like the U.S. have already put their money down.
Yes.
To multiple drug companies to get the vaccine.
Yeah.
And so who's going to be left out, right? You're not going to have 1 billion doses ready when a vaccine is approved. Okay, so who's going to be left out? Yeah, interesting. We'll see what happens in the next few months, and maybe you should do your own challenge trials. Sign up with a drug company to do that. Well, we'll talk about that. All right, guys. I know it's getting late for you, and I want to appreciate meeting you all, and thank you for your participation. And I look forward to the next several weeks. Okay.
Thank you, Professor.
Let me know if there's any changes you want to make. Just like the adaptive clinical trial, I always believe in adaptive presentations. Okay. All right.
Okay, thank you very much.
A lot of fun.
Thank you.
Okay.
Thanks very
everybody.
much.
Thank you.
Thank you.
Good night. Good night, everybody.
Good night, everyone.
Good night.